Welcome. In my presentation, I will be talking about the design of the study and also non-indicative drug usage and their interactions. When we look at the world as a whole, child death under the age of 5 is still important, but at the same time the number of chronic diseases increase, and for the treatment of these diseases many drugs are being used in different combinations. And as stated by Nadir Bey, rational drug usage becomes very important, especially in children. We know that 50 to 90% of the drugs used in children have never been studied. When we say rational use of drugs in pediatrics, right prescription of the appropriate medicines and probable adverse effects should be prevented, and medication errors should also be prevented. The children are more sensitive to adverse reactions, and there are many factors like psychological, indirect and iatrogenic factors. When we look at the physiological factors, the age groups are important, and pharmacokinetic characteristics, age is very important in that regard in terms of the realization of the drug. Polypharmacotherapy, length of hospital stay, and polymedication, are risk factors. As the length of hospital stay increases, these adverse effects increase, and adverse drug interactions, it's not only happening because of the use of the drug, they may result from drug interactions as well. There may be cases in children where multiple drug use is required due to some metabolic diseases and other chronic diseases. The more drug you use, the more drug interactions might be there. What is drug interaction? It is the change in pharmacokinetic or pharmacodynamic properties of one or both of the drugs formed by the co-administration of two or more drugs. This is the definition of drug interaction. As a result of this interaction, there are three different results: decreased action of drugs, increased action of drugs, or adverse effects. And these adverse effects can increase up to toxic effect and may result in death. And children may be more vulnerable to the effects of drug interaction due to age and pharmacokinetic differences compared to adults. But it has not been studied well in that regard, and the results become more sensitive. And there are a couple of studies that I want to share with you. This is a retrospective cohort study in patients under the age of 21 years old, and drug interactions were evaluated. Micromedex solutions were used. We can check it through database. Micromedex database was used in this study, and this database, you enter the names of the drug and you can see the interaction, type of the interaction, and also evidence levels. You can see all the details, and through this program this study was conducted. About 500,000 children were evaluated, and in 50% of them there were associated potential drug-drug interactions, and 41% of them major, 28% moderate, and 11% mild drug interaction. There's another study which was conducted in 915 pediatric patients, and Medscape was still used. It's like Micromedics. It's similar to Micromedics. Its difference is that the classifications are a little bit different. Severity classification is a little bit different, and it's free. And in 61% of the patients, at least one potential drug-drug interaction was found. 3,631 potential drug-drug interaction. These interactions, how are they affected? Female, gender, age, hospital status, the number of administered drugs do have effect in drug-drug interactions, especially immune system diseases, blood diseases, nervous system diseases. The number of drug increases in such diseases, therefore drug-drug interaction risk increases. When we look at psychiatry, as it's the case in the adults, the use of antipsychotic drugs in the treatment of various psychiatric disorders in children and adolescents, and it's inevitable, and it increases the drug-drug interaction risk. When we look at their main mechanisms, we can say that there are many drug-drug interactions in the use of antipsychotic drugs with other drugs. They are metabolized by phase 1 reactions, and it happens through metabolization pathway, and they might come as serious interactions, and this pathway is CEP450 enzyme system, and the basis of interactions is the inhibition or induction. With atypical antipsychotics and anti-epileptics and anti-convulsive diseases interact the most. What about the results? They can lead to many problems. QT prolongation, neutropenia, increased sedation, increased anticholinergic effect, decreased blood pressure, increased seizure risk, weight gain. There are many adverse effects. And the aim of the study was to detect the possible drug-drug interactions and duration of the interactions between antipsychotic drugs and other drugs. And the method, it was a retrospective study, and in patients who had been consulted to the Child and Adolescent Psychiatric Clinic and who had received psychotropic medication, and inclusion criteria was that patient should be using a psychotropic medication. Hacettepe University, İhsan Doğramalı Children's Hospitals, all departments, and it lasted about a year. And 2 clinical pharmacists evaluated psychotropic drug-drug interactions, interaction results, duration of interaction exposure, and number of the drugs. And data source was the electronic database system and drug orders. Potential drug-drug interactions, when we look at the Micromedics Solutions database, drug interaction section was used, and it classifies the drug interactions into 4 levels of seriousness. And when we look at them, the seriousness category, the seriousness category of interactions, contraindicated, major, moderate, and minor. It shows us the severity of the interaction. When we say contraindicated, drug pairs should not be used concurrently. When we say major, it may be life-threatening or require medical intervention to minimize and prevent adverse effects. When we say moderate, it may result in exacerbation of the patient's condition or require an alteration in therapy. And when we say minor, it's limited clinical effect that may include an increase in the frequency or severity of the adverse effects, but generally would not require a major alteration. And during this 1 year, total 598 inpatients consulted to the Child and Adolescent Psychiatric Clinic, and 2 inpatients, they were using at least 1 psychotropic drug. When we look at the results, 59% of the patients were female, smoker, alcohol consumer, substance abuse. In 17% of the patients, there was psychiatric diagnosis, and the average age was 11, number of drugs 7, number of drug interaction 1.68, and antipsychotic drug 1.29. When we look at the breakdown of the results, general pediatrics, hematology, intensive care units, and others. When we look at the number of psychotropic drugs per patient, the average was 1.29, and 151 patients using only one drug, and the remaining were using 2 and more psychotropic drug. And total number of drugs mean, the average was 7.39, and the most commonly used psychotropic drug is escitalopram, and 336 drug-drug interactions were found, and number of DDIs seen between 2 psychotropic drugs was around 15%. And the results, when we look at the average duration time of exposure to drug-drug interactions, was 8 days, and the most common drug-drug interaction was escitalopram and ondansetron, and it was QT prolongation effect.
258 ilaçta
out of 258 drugs, 2% were used within indications, and 66% of the patients were using one off-label psychotropic drugs. And total number of off-label drug interactions was about 80%, and escitalopram was the most commonly used off-label drug, and we've seen that escitalopram was used also even in the youngest age groups. These are the other drugs, distribution of escitalopram interactions. You see ondansetron, granisetron, fluconazole, so we see QT elongation here, and in fluconazole and granisetron, it causes an increase in ST. Interactions of off-label drugs with other off-label drugs. When we evaluate them, we find most interactions between escitalopram and quetiapine. Off-label use of medicines for children is common both in children and adults, but as with many other drugs, many of psychiatric drugs used in children are used off-label because they have not been tried. It's 50 to 75% of pediatric medications are off-label. Well, looking at the term off-label drugs, the healthcare authority of the country define indications based on disorder being treated, demographics, and some other factors. If falling out of these factors, that's called off-label. Of course, being off-label does not constitute contraindication. What we need to be careful is we need to evaluate both the efficacy and the adverse effect in case of off-label use. There is a study of off-label prescribing in pediatric outpatients. We find 56.4% unapproved indications. Another study in the field of psychiatry. Of course, drug interaction. We will run into those all the time, but how can we manage them? We can change the dosage, we can do therapeutic interchanges with similar products, or we can adjust administration times, especially If the adverse effects reactions are high, or if they are newly initiated, first dose monitoring is essential for managing drug interactions. In pediatric patients, increasing drug number of chronic diseases, and duration of hospitalization. Therefore, because of these factors, there is an increase in drug interactions as well. Psychotropic drug usage is also common in pediatrics, and in our study we saw that 1/3 of patients had one potential drug-drug interaction. Rate of the off-label psychotropic. So what's important as a conclusion is we need to be aware of drug-drug interactions. We need to monitor adverse effects and necessity of off-label drugs. And management patient treatment with a multidisciplinary team will also be beneficial in detection and management of drug-drug interactions. And this multidisciplinary team could include physician, nurse, clinical pharmacists, dietitians, and maybe professionals from other disciplines. And this will help us optimize